And when they are interconnected, you create the system, which is physical system, which is the body, the energy system, which is pranamaya, that means energy of the energy level, and most important are the rest three, which is specific to the human being, which is the thoughts, which comes as either intellectual thought, or as a common thought of survival, or as an emotional thought that you generate. So all these three thoughts are called as a thought, and these three actions, these three systems are in constant interaction with us, in all of us, basically, even today. The energy state changes through input either on physical or mental level. Any of these components, if they are changed by any means, let's say for example, you developed an injury, that is a physical component which is affected, you immediately become sad and your energy level goes down. So any of the factor can be affecting, and the whole system gets affected. Now energy represents the currency or the medium of exchange for a psychophysiological system. It's a reward and punishment kind of a theory. And the three levels together can be named as the brain. This is from Upanishad, which is 6th century BC, which is still kind of many way superstitiously followed in this part of the world. So on return back from my fellowship was in '99, and I joined this very beautiful hospital, legendary hospital in the private sector. It's a trust hospital, Sir Gangaram Hospital. I think this is the place where at least a few of our fellows did the fellowship here. And this was the first department created in India as a neuroendovascular therapy department, away from the neurology and neurosurgery. Now why these things are important to us today is that anything that you do against a stream or path breaking brings the resistance to you. So resistance is an integral part of the development. And that's where Fritz persisted, because Fritz remained where it remained. If we would have yielded or was broken down to the resistance and the challenges of the time, whether it was availability of material, affordability of the cost, or understanding of that procedure, or any political issue which was interfering, would not have been this community today. So we dealt with all possible procedures available at that time, gradually studying. This is one of the stent-assisted coiling, one of the first ones. We started in 2005, the fellowship program. Very quickly I started. Many of my colleagues said that, oh, you don't have many cases to perform, and if you teach to too many people, they will take away your business, because you earn only when you work. This was a system of work in this hospital. But I remembered always something from the company of these, especially Lachonias, Valavanis, Picard, that often it was mentioned by Lachonias, Pierre Lachonias, that knowledge should be not swelling in one place. You should not retain the knowledge within you and swell into a big tree. Rather, distribute or implant as a seeds and seedlings all over. One day they all will grow into a tree. And this is exactly came to my mind that if that is a fact, then it's a vast world. There is a plethora of patients. It's not that I'm going to treat all the cases of India. It's impossible to do that. So why to worry? So we can see that when you do not hypertrophy, is to call it, don't hypertrophy, implant the seeds. So we started conducting workshops in India and Bangladesh to start with. And later we started in other part of the world also. So this was a time for the need for creation of this foundation. And one of the important reasons was that challenge where my own neurologic community was resisting. Of course, the radiologists were not allowing you to enter in their department. Of course, the cardiologists were allowing partly, but in odd hours, to learn from you so that they can intervene into this system also. And rest other were the silent spectators, enjoying the game of resistance and the politics. So we were not offered any platform to develop academic, scientific and professional work. So I created this foundation with the sole idea that the whole mission would be to create an educational platform, train people on this platform. So Stroke and Neurointervention Foundation was created in 2007. We started the activity earlier without the platform also. We started daily course on neurointervention, and you can see this in this picture, this young boy from Jakarta. He came to me and he says he wants to become an interventionist. At that time I also thought that maybe he's just infatuated. He's wanting to, we have to judge. Because in the understanding of Professor Balawan is, it takes very, very long time to become a neurointerventionist. Or probably you do not become actually a neurointerventionist. You just do the job sometimes. Because the learning is a constant process. It doesn't end with even 50 years. I saw him, I visited Professor Balavanis when I was in 2017 to 2022. He called me to Zurich to take, when he was retiring his position. I visited a few times at home because he was keeping him isolated from exposure to, it was a corona time, and then later on he was on immunotherapy for his illness, so he was retaining himself to an isolated environment. He was not interacting with people. So occasionally he went there. Once I was there in his home and he was sitting on his computer with lots of books and those things around him, lot of CDs. And he says, I'm preparing insula. So he was working deep onto the insula and insular vasculature and insular pathology and advancement of his understanding of that actually, which he could probably share eventually on a lecture to us. This is how he used to perform. So he did visit my center. Later when he was coming every year for the fellowship program, this daily course, he was integral part of the course, which I started on the same line, on the same philosophy, same idea that the Zurich course was, that is, we kept industrial conflict completely away from the scientific world that we created until today. So no industrial component or any hospital agency could not influence what you will deliver and what would be your faculty and what knowledge or what lecture you will make it over here. Today you go to the major conferences, there are luncheon seminars which are 100% sponsored. It is for a purpose, very clearly, with a strong conflict of interest. They choose the speaker and they choose the subject and they choose to show you what they want to show you. So these conflicts are there in our world, but there has to be a knowledge base, which is accepted, which is welcome, which is part of our many interactions. Through that also we learn many things actually. So industrial participation is important, very important, but not at a level of exploration or deep science learning. So when he visited us, and I think you can see Dr. Hermanto, Subito, and Dr. Antonio. It is later. Dr. Fritz has already went back. And what he did very interesting and intelligently is that he started choosing one after the other, and he will communicate. Only the candidate coming through this pathway will be accepted. Many fellows were applying from different parts independently, and I then realized that he was right in certain way. he was wanting to develop a program in a very orchestrated manner. He said to me one thing which attracted his proposition. He said, most of the people will come from Jakarta, and Jakarta will be full of it, and will be as such, we are not able to start, and there will be more fight internal also, and we will not be able to take off. This was a remarkable point. And he selected people from different regions, different islands, and they visited us. So when the Professor Valavanis was into my laboratory, this is what he told me. That looking at the angiographic picture that your results, I couldn't imagine of the primitiveness of your workplace. Because this was a mechanical C-arm. The table and the machine both has to be moved. And this is a very low intensity machine in terms of cooling. I cannot use this machine for more than 30 minutes or 40 minutes of continuous use. And you know that in neurointervention, some of the procedures are lasting. In the early part of the learning curve of my practices, even in aneurysm, I would take 2-3 hours. But subsequently, we did try some aneurysm just in 30 minutes. Why it is important? Because this machine, those who have seen, those old fellows who have seen, in fact, they have done this job for me, obliged me in that way. That this machine will heat up and it will stop. The X-ray tube will become so heated that it will stop with autocut. So then you have to halt the process, number one. And our immediate mechanism was we had a lot of green sheets, the draping sheets that will cool down with the cold water and remove the water from it so they are very cold and put it on that X-ray machine, X-ray tube. And this was like a rotational work. If I had more fellows and more people around it, that will go longer because they will be changing the hands and they will be cooling the C-arm, and we can do a prolonged procedure. So just you can imagine that how beautifully it's a teamwork. It's not just changing that drap. You are part of the procedure, and I give enormous consideration to these things. Extremely enormous. They were sometimes my helpers. They were all like ordinary boys working for the service, cleaning the lab. But they were, I would say, we did the case together, because if you would not have cooled this machine, I would not have used it continuously, and I would not have probably completed the procedure in time. Because you prolong the time, you increase the complication rate. This is also a very important point. I'll come to the philosophical learning point which we have from Zurich School in the end. So, subsequent to that, we had an establishment of the daily course, and Michiro since then has been an integral part of it. So we had a constant faculty, Professor Valavanis, Michiro, my dear friend Bernd Tomandel, and Rodesh from France. We continued this in the same spirit and same philosophy. So it was exactly a Zurich course for the Asians. Because everybody to go to the Zurich was very expensive, extremely expensive. To stay there for 1 week, we know that you can go maybe once probably, if you are a famous practitioner, you can go every year also. But for the young learner, it is impossible to go. So this was a very, very important, I would say, development, and we started developing some centers in India. And this is a very important place. This is a EMS hospital in Perinthalmanna, Kerala. This is the reason why I am today in Kerala. Now this is the hospital, which is about 700-bedded hospital. You know the size of the town? It has, I think, around 50 to 70,000 population. In Indian context, 70,000 village is a like insignificant village. Because even the villages there are a few like 100,000, 200,000. And small towns and small cities are even very, very crowded. So in this small place, there were 3 such major hospitals. The population is just 50,000. So they were catering to a lot of patients in some specialties, orthopedics and cardiology. they were coming as a medical tourism to this place. So we started developing with my colleague Dr. Moinul Haq. Hope he's here already? No. So we started developing this center with the using cardiac lab. And several workshops we conducted. We conducted workshops in Indonesia also. And interesting thing is that in early time when I had some visitors like Osama Zaidat and John Lynch and some of them, Yavagal, they were still not into the field of neurointervention. At that time they were wanting to get into the fellowship, which was restrictive for them because INR will not allow them to enter the field. So when they visited my place and they saw the things, they were very, very impressed. They said, we want to write into the thing, the primitiveness and development of neurointervention, because this would be enormous encouragement to the American population, because they complain that without cath lab and without this system, how can we do it? So one of the major limitation over there was that if you don't have a setup, how we can do it? So they wanted to show that you can do it. You can do it even using a C-arm, which is available in most of the operating theater. Because spine surgeons, orthopedic surgeons, they use these C-arm machines. Subsequently, we developed on the similar line and philosophy of Zurich, very comprehensive. This is our best development that we had, which was the Sakir City Hospital. And some of who were there in Sakir City, Kognard, and I think 2-3 of you. So I think Yovita was also there. Three or four people were there, and this was, I think, this was our dedicated seminar and discussion room of the neurointervention. This is our dedicated ICU attached to the cath lab, which is a pipeline machine, and Philips pipeline, and this was, I think, the very, very beautiful program. I had an opportunity to interact more with this group, very strong group of Zurich School. From 18th course, Professor Valavanis gave me a lecture on speaking on carotid stenting without protection device. I think from that period to 24th course, we spoke more as a part of the Zurich course, and it allowed more closer interaction with the faculty and the eminent participants which were there in Zurich course. Was very, very learned participants from different parts of Europe. They were not learner or primitive people, but they were practicing people to continue to advance their skills and knowledge. And the phase of the advancement of the Delhi course became very popular. We started doing extensive workshops and teaching programs and hands-on experience of material usage, which was often we were asked for. In the program also we had so many of you learning all these within the program, and this was another turning point for us. For me, as a surprise, just suddenly one afternoon, I opened my email account. It was Ramadan time. I was fasting. And I saw an email from Professor Valavanis asking that I need your help and I want you to come to Zurich. I thought maybe I didn't understand what he meant. And then he called me and he explained me and he says, can you come here for a weekend? So I traveled for a weekend, and at that time he called my colleagues, Kulcher, Zolt and Stipich, who was the chairman of neuroradiology, was not an interventional person. Zolt Kulcher was the only interventional person. So we 3 and 4 people, we met at his home and we had a discussion, and then it was a journey transforming to a new direction, and it was a mixed reaction for me. It was an enormous honor and enthusiasm I had to work in Zurich. On the other side, I had a large practice established over the last more than 20 years in Delhi. I had many scheduled cases already with me, and I had a running fellowship program. I had 4 fellows, including Dr. Dedi and Shankar, and 4 fellows, one other guy, 4 guys were doing fellowship on a halfway. And my team, most important, which was constant in every hospital, from Gangaram to Max to Sakir City to Neo, the whole team was moving with me, and I had a full responsibility for my team. And if I move out, my question was, I immediately accepted him, and I said, okay. His thing was like, I need your help, and it was like, at that time, it sounded to me, in our Indian, I do not know whether you are aware of this, I think you know this, Mahabharata. So in Mahabharata, there is Arjun and Krishna. And Arjun is a warrior. He is from elite family, the ruling family. And his teacher who taught him the archery was a Dronacharya, was a teacher par excellence. So this prince went to Dronacharya to learn the archery, to be the best archer in the world, in that world that they were. There was a guy who was underprivileged from a low class of this thing. He was like a jungle boy. When he saw that the teacher was training the Arjuna, he wanted to become archer as well. So he went to Dronacharya and he said, I want to be your pupil and I want to learn from you. So he said, okay, let me see what you can do. So when he was a jungle man, jungle boy, he knew archery. So he did a play and it was pretty good. So, but Dronacharya said that I cannot accept you as my pupil, because he saw is a talent more than the Arjuna, who is a prince, and they wanted to develop Arjuna. So he said, no, I cannot accept you as my pupil. So you know what the Eklavya did? His name was Eklavya. He sat down, every time when he's teaching him, he will sit down on one of the trees around and will watch the lessons that he's giving to him. He will follow. And after taking the observership, so he was an observer to that mentor, to another pupil, and he will go back to his corner away and he will follow the same tricks and he became a master. So in one of the competition, when he showed that he was above, he was a winner, Arjuna couldn't actually score over Eklavya. So he called him that, where you learned this archery from? This was after many years. So he said, from you, my teacher. But he said, you have been never my student. So then he told the story that I came to you like this and you refused, and then I watched you. And so he created a small statue of him, and he would keep him as a guru there, and he would practice it with the submission. So this was a devotion, submission, and clarity of the things to do. As Dr. Michiro said, that he could have played, any other weapon also, but he just wanted to be archer. So then he realized that, okay, if he does the same way, then Arjuna can never be the leader. So he asked that you have to give us a Guru Dakshina. The Guru Dakshina is a method when a teacher prepares a pupil, he asks that to give submission to something. I give you something in return, because you are kind to teach me without any gain from me. What do you want? So teacher may ask anything. So teacher, when he said, okay, if I am your teacher, so now you have to give me a Guru Dakshina. You have to return back to me what I want. He said, yes, my teacher, what do you want? He said, your right thumb. He took out the knife and he cut down his right thumb and submitted to the teacher. So this story is also taught in the school, because it has a lot of moral teachings into it. This is another story that most of the people, they in Indian setting, they value Dronacharya's value as a teacher, but many people, they value rather Eklavya as a pupil, because he submitted his thumb to him. Anyway, so this transformation, my movement was very, very important, and very important for the point that it was one of the best system, I would say, that it was developed or developing as far as the stroke care management is concerned. Because my training all before that was primarily on hemorrhagic strokes, and now was a time when the popularity on the acute stroke management was happening. So this provided a excellent ground for me to conceptualize and learn the whole concept of cerebral blood flow, penumbra, collateral circulation, clot burden, not the technical aspects. Technical aspect is simple. This is often taken as a main training part. It's not important. It is 10% of the things in the statements. This is not my word only. This is what Valavanis used to tell us, or the Picard used to tell us. Learn the subject, the knowledge, and the understanding on the subject. Technique is your natural, availability to you. Or you start practicing, it is nothing great into it actually. Sometimes you do not know and you can actually do the trick because that's instinctive. So, we developed a protocol of the SNIF protocol in the same form, almost in the same form as the Zurich protocol was. But we had to modify because Zurich had a system which was very eloquent, very well managed, and very foolproof in the sense. An Indian system is everything is movable or everything is unclear. So we had to make a working model or approach which can be applied more or less in the same Zurich philosophy and Zurich model of work. So these are the two protocols that we still follow. Those who are interested, probably these are all. This is a protocol what we need actually for Asia, because we have a common problems. That's one of the important point is the limitation of the cost. So how to deviate from that and how to make a correctiveness in this regard. Now, Professor Valaman is always insisting on this training model, and this is what he has written in his book on intervention neuroradiology. In an evolving complex surgical field, he considered interventions as a surgical field, such as intervention neuroradiology. Now we also call it intervention neurology or endovascular neurosurgery. Neither a book nor a series of didactic books and lectures can replace proper training. So most important in this work is a proper training. So going according to his philosophy and his idea, we were nurturing the training program of the learning program in Asia, especially focusing to the Indian subcontinent. We expanded our the abilities to presentation of the cases with by posting clinical data and neuroimaging when discussion plans with the faculty members on site or online, which is we use WhatsApp system because earlier they were not there. So now WhatsApp system is a very, very useful system for us because we have a protocol to communicate. Let's say for acute stroke protocol, there is aneurysm protocol, there is AVM protocol. So they will have a common language every time, and every operator will have the same question to be played, all information to be placed in the same box, same format, and delivered to us, and then discussed. Emergency cases, face-to-face online proctoring of the cases that we do. Discussion of the pre-operative planning, which is extensively done with all the fellows and the former fellows, which is a continuing process even until today. Clinical workshops on site and online, which is Zoom meetings. Again, these are the clinical workshops with only entry to the fellows. We do not allow for reasons which are important because these are actual cases, and for this we take a written consent from the patient and the family also to expose them to the online proctoring. So telementoring and teleproctoring is now more and more possible because earlier I was doing the on-site proctoring as the number of now fellows are plenty. I cannot travel to every place to do an online on-site proctoring. So what is more popular today is online proctoring that we do. And how do we use online proctoring came into the play, especially in the COVID time, and there were a lot of American companies and technological companies. They came with these beautiful devices that they created, and they became popular in western part of the world. And the most important thing for this was such an expensive instrument that you have to have. So what our resource depleted environment or resource limiting environment that we have in India and Asia, we developed the technique, tools just by using a tripod and two WhatsApp, systems. That means two smartphones, which all of us have it, right? So we'll use two phones, one attached to the monitor and second attached to the side where the hand movements are visible. And then this would be relayed on the Zoom meeting, and all other fellows can also participate and watch the instructions of performing the procedure, which is extremely important. But before that, so this proctoring, I do it any time of the day and night, practically speaking. I do from my office, I do from my lab, I do from my cycling in the hiking, and I do it from my railway travel. I do even while I was boarding, once I was doing continuation of the proctoring of these procedures, and every type of the complex procedure, including one of the situation we did what do you call this? This is from Zurich. This is the first time Dr. Gautam, some of you know him, has to perform this flow diverter placement. He has never done it. He has never offline also done the use of this device. And in Zurich we have what you call another old lab which we have placed in another building for training purposes. And Alan is here. Alan is a head technician in Zurich. Hi Alan, good to see you. So we used to create this place for actual training. So this was when I reached there, it was defunct actually, nobody was using it. So I set up again, collected all the materials, and we set up the